Thank you, everybody. In this session, it is correlating echocardiography with other imaging modalities. We have a pan-India expert panelist. One from West, Dr. Nitin Borkule. From the North, Professor Dr. Sir J.C. Mohan. From the South, Dr. Allegation. And from the East, Dr. Anup Bhargav. So I'm lucky with this panel to present these important issues. First is the echo and the CT thorax. Here is a story of a 23-year-old lady presented with a generalized weakness, easy fatigability, dyspnea of exertion for the last few months. Physical examination is except a soft ejection systolic murmur in the precordium, otherwise normal. Routine lab study, no significant abnormality, but the chest X-ray reported as cardiomegaly. You can see the chest X-ray, and with this chest X-ray, I'll go to echocardiography. I'll show you the different clips, and this is an off-axis four-chamber view. We could not get the four-chamber views properly, and this is another view you can see, and this is the parasternal short-axis view, where you can see there's a large mass sitting on the mediastinum and anterior mediastinum, rather, and compressing the right ventricular outflow tract. It's a variegated appearance, and you can see some turbulence in the outflow tract. And you can see outflow tract is getting a little narrowed with the pressure of the, and see, this is the outflow tract and the gradient of near about 35 millimeter of mercury, not much. And from these, Professor Mohan, any your suggestion, or for the audience, anything you can ask them?
No, so the way I look at this mass, actually, as you rightly said, it is a mass in the anterior mediastinum. It is in front of aorta, in front of right ventricular outflow tract, and is compressing the right ventricular outflow tract. The mass is extrapericardial, and also it's a large variegated, and of course there are spotty echolucent areas, multiple. Now beyond that, and we did not actually put any color, we didn't put contrast. The two things one could actually get help is by putting color. That is one thing we could see whether it's a vascular mass or not, color flow map.
It is not vascular, sir.
Yeah. The other thing probably I would definitely do is try to put the sonoview or something. That can also tell me how vascular the mass is. I mean, those we know the limitations of echocardiography, but that would have helped me with this. Having said that, can I now say what this mass is? Is it a benign tumor? Is it a malignant stuff? Is it a large thrombus? With that kind of, it is difficult for me to.
So it is so far from this echo, it is good. Probably this is an extracardiac mass.
Yes, all I can say is an extracardiac mass, and the areas of echolucency, actually, if those I consider them as necrotic areas, and these are not vascular spaces, then I have to believe that some kind of tissue apoptosis necrosis going on, this probably is malignant mass.
It's not a vascular. We put the color for this slide is not there. But one thing is that the sonoview is going to help, Nitin, Dr. Nitin, sonoview is going to help in the extracardiac mass.
Yeah. See,
that the contrast will go everywhere.
Everywhere. Yeah. See, the first thing is that anterior mediastinal mass superiorly located. I think vascular, anything outside the heart, obviously echo has limitation, and the cross-sectional imaging is better, like CT. However, I think the best thing we can do is vascular versus non-vascular. So I think contrast can definitely help you. If the contrast lightens up this, then you are very worried, because that is probably malignant. And except that a primary hemangioma, which is not
keeping the variegated appearance and all these things.
But so this can be teratoma, thymoma, anything can be. But vascularity will be the first thing that the echo can tell us.
Due to lack of time, I'll go to, is the better investigation if you do the CT. So this is the CT pictures, you can see. And here Dr. Bhargav can describe, I can better than me, that what is the mass you are seeing and what is the characteristics of the mass. And I'll show you a series of CT pictures, if you can could. Age of the patient, I told you. Something, this is a story of a 23-year-old lady.
Yeah, basically anterior mediastinal masses, we have this.
Yeah, seeing the, what is the findings you are getting, you can tell the audiences what about the.
So there's a large solid mass with multiple necrotic areas lobulated, and it's.
If you need more slides, I'll change it.
And it's not enhancing.
Next one, this is one. Any further information? Or go to the next one. Laser beam? I cannot explain to you. You can give the laser beam. I give the laser beam. Another one.
The mass is also adherent to the anterior thoracic wall. And it is
This is the mass.
exophytic growth through the rib cage and under the skin.
Achha. And I think another one slide is there, another one. And this is the last one. So far, I learned from my radiologist friend what is there. The first C is
we
that
think of
these one, there is a variegated appearance of the mass with the specks of calcification around. But it is not a homogeneous mass.
It's not a
Absolutely, the
homogeneous
anterior
mass.
mediastinum
Yeah.
is a non-homogeneous mass.
So we think of 3TL. 3T
So what is the diagnosis from the CT? What could be the diagnosis?
either a thyroid mass or a thymoma.
Thyroid mass or thymoma. This is your diagnosis. So this CT reported that, see, this is the large homogeneously enhancing solid cystic mass in anterior mediastinum, anterior to great vessels and left part. It shows smooth margin with curvilinear fine calcification and most calcified focus within the mass. This is a measurement, and they reported as a query germ cell tumor suggested biopsy. Well, we did the biopsy, and this is the biopsy report. This is the thymoma type B3.
Yeah.
Very interesting fact about that, the type B3 thymoma or epithelial thymoma are well-differentiated thymic carcinoma. 10 to 14% of all thymomas in 20 years survival rate is 40%. 46% are associated with the myasthenia gravis. In fact, in our case, the patient presented with the clinical features of myasthenia gravis. Patient was advised for optimization of the medical treatment for myasthenia gravis before surgery by using cholinesterase inhibitors. And the next case is echo-CT angio. Here is a story of a 47-year-old male presented with the heaviness of chest, dyspnea on exertion, mild cough, and the back pain. That's all. And this is the chest X-ray. Dr. Bhargav, any idea about the chest X-ray? Anything? Any
I would think
any
of
diagnosis?
a neurogenic tumor.
Could be neurogenic tumor, of course. Any of the panelists?
Could we think of pseudoaneurysm of the aorta?
Yeah, could be.
Pseudoaneurysm of the aorta.
Yes, that
And
could be.
with-
The
with-
position is very, very important.
Yeah,
for the
with
aortic valve.
calcification actually at the
Yeah,
periphery.
is there a linear calcification, sir? That's very.
Is there a history of trauma in the past?
No history of trauma,
No
sir.
history of
Patient
trauma.
denied history of trauma. Actually, ask for it. What you are doing is very important for that. Because as I go to the case, and that is very relevant.
See, the point is, this kind of thing we have seen in people
Yeah,
with a
yeah,
past
yeah.
history of
Absolutely
trauma.
correct.
They have pseudoaneurysm at this point, typically involving the post-subclavian
Absolutely,
junction,
sir.
the isthmic
Absolutely,
junction.
absolutely correct, sir. So now I'm going to the very interesting fact about that. I'll go to the series of echocardiography. This is a parasternal long axis view and is absolutely normal. You see, the color flow is doesn't showing anything, and this is the 4 chambers view, 5 chamber view, whatever you called, short axis view. And this is the ascending aorta. I'm trying to image it, and it looks good. Now go to the descending aorta, also looking good, but it's not a good picture, I'm telling you. But still, whatever I could see it from the descending and ascending and the arch of aorta, this is the picture. Then I saw a little bit swelling in the patient clinically in the left infraclavicular area. Then the patient did not say anything. Then I put this is the Doppler in the descending aorta, and there is no diastolic flow. And this is the picture I saw in the just left infraclavicular area. Then you see, this is pulsatile. Then putting the pulses in is not so much, but still pulsatile, feeling pulsatile. Then I put the color. Putting the color and reducing the Nyquist limit to 26, then you can demonstrate the flow inside it. And this is the picture, and this is the picture, reduce the Nyquist limit in that only that particular area. But I could not go beyond with this transthoracic echo. Then the patient was lost follow-up for a few months and then came back to me with CT thorax.
Yeah, before that, this doesn't look an arterial flow. This looks like some AV communication probably.
I could not demonstrate.
Yeah.
On the echocardiogram.
Yeah, because if it was an aortic aneurysm, you won't have this kind of a low velocity swirling flow. So
Why do you
I
think you are calling it a
expect
pseudoaneurysm or aneurysm?
no, I think there could be some AV communication, and what we are seeing is probably the
AV
encouragement
communication in where? Where AV communication?
of subclavian arteries with
Subclavian
subclavian
artery.
vein or something.
That could be. Is a possibility is there.
I think he has reduced the Nyquist limit to significant extent. My gut feeling is this is probably a pseudoaneurysm of the thoracic aorta. Yeah, and the flow is in the sac. There is some spontaneous contrast also visible.
Yeah.
Little bit of spontaneous contrast visible. I know there can two things one could do actually. One is of course somehow a better resolution. TE could be done. A better resolution machine could be used. I mean, these are obviously, of course, if you do a CT, things would become clear.
Now is the city. No murmur, except maybe a benign or something murmur. Because I could not demonstrate important murmur. But this is the city. Also, a city. I am not a city expert, but what I got for my radiology colleague. So these are the city pictures in the different pictures in the same area, and this is done in the KEIM Hospital, Bombay. And this is after the city pictures, you can show the city pictures, and they reported this. Still, they have put query aortic aneurysm. They have not confirmed. Yeah. So this is the report. Then this patient was done cardiac MRI. And see the MRI plates. This is the MRI. This is again from the KEM. And this is the report again. Same report, query aortic arch aneurysm. Ultimately, they did the CT aortogram. And the CT aortogram ultimately give you the diagnosis. See, this is a real aneurysm, and this is not pseudo, sir. This is actual aneurysm. And in fact, the reported is that, and also they give the large aortic aneurysm involving the distal aortic arch and the left subclavian artery. This is their report.
Oh, this is actually.
Can you see that arch?
I am doing.
Because there it looks as if it is a narrow neck.
I think it is a pseudo.
I don't know.
I don't think it is a true aneurysm.
I have a question. Mohan, was the MRI necessary after the CT, or you could go on to
Not necessary. It was not necessary. It was CT. After that, CT aortogram was necessary. But I am giving the follow-up of the patient because this is not, that time he is not my patient. He again came to me with all these reports and then compiled it. And this patient was, a surgery has been done, and this was a true aneurysm, sir. This was a true
CT
aneurysm.
angio could have been avoided. MR angiogram would have done also.
MR angiogram.
Yeah, if you give the bolus with tracking,
One CT aortogram was
you can
there.
get the same picture.
Another picture was there, another CT 3D reconstruction of the CT was there, and that was, I could not get this one somehow. This is the report from the KEM Mumbai.
I'm still surprised. What is the basis of calling it a true aneurysm? What did they find in true aneurysm? There was,
There
did they
was
find
a
it-
communication. There
No,
is
the
a clot
communication is
inside. There was communication, and ultimately the
No,
surge.
see, the point is a true aneurysm, one which has all the three layers,
All the
intima,
three
media,
layers,
and
yeah, obviously,
adventitia. This is whole, the wall is calcified. It will be tough for me to say that it is a true aneurysm. Simply based upon the neck, whatever is the width, this location is typical of pseudoaneurysm.
Agreed, sir.
The other thing is that if I'm given 9 out of 10 times a mass like this here would be a pseudoaneurysm of the descending thoracic aorta actually. So I'm a little bothered about all those tests.
Difficult to
done.
digest.
Yeah, difficult to. I probably, if I was the treating person, I didn't have the CT or MR facility, I would put a catheter and do the angiogram. I mean, it's simple. It takes me 5 minutes to do it from the femoral artery, and it will solve the problem.
That's why actually I inquired why they didn't do the angiography properly. Because this patient was being seen in 3 important hospitals in the.
And before that, I will do a TE. Actually, TE is also much simpler way of solving this issue. In fact, I would have seen the neck much better actually.
The T will be absolutely definitely in the arch of that is in the descending aorta with all 3 aneurysm. Very well. Huh?
You have got that blind spot on the anterior.
Arch only. Yeah.
That too a part of the arch.
Yeah. Absolutely, it is area is there that the neck attachment is absolutely just beyond the subclavian artery, just beyond the subclavian. Very well seen.
So the isthmus, close to isthmus is the break point. Actually.
Break point. Okay.
Just below the isthmus.
Okay, sir. So could be it is a pseudoaneurysm or aneurysm. It's.
Actually, I'm still impressed by this thing that it is to be on safer side. Call it aneurysm. Pseudo or true doesn't make a difference. You still have to chop it off and repair it.
Surgically, there is any difference to do it?
Yeah.
Anything, but aneurysm it will be difficult for the surgeon. Obviously, pseudoaneurysm is much easier to control. In fact, pseudoaneurysm, if there is a pseudoaneurysm, then if you can neck the hand, in the neck there is nothing to do. Anyway, now we'll go to the next case. This is the echo MRI. Here is an important story. This is a 75-year-old man presented with the dyspnea on exertion. With the 2 echo reports I have seen, and this is the echo report. Similar to that, there's 2 echo reports. And then I took the patient, one of our senior colleague, Dr. Aniruddha, sent this patient to me. And this is the chest X-ray of the patient. And the patient was probably in the failure, that's why there's some pulmonary edema is there. Here is the ECG. This ECG is unremarkable, but I want to ask one question from the learned gatherings. Then I did this ECG in a 20 millimeter standardization, and what I saw is the P wave. Is there any abnormality in the P wave seen? Or it is normal variant? This is in the V3, V4. That was. This U wave seen. I don't know.
See the T is abnormal. The way T is actually falling, the descending limb and descending limb is abnormal. U is abnormal, so there is a definite repolarization abnormality.
Okay.
And I think the QRS duration is about close to 100 or maybe 100.
Is it not a double P or something? No.
So that is a U wave.
U wave.
Positive U wave. P wave is a little different, and PR interval is all right. And a QRS probably 100
Okay.
milliseconds.
Okay.
That's all I can think of.
Okay, no, forget about it. This is my actually query, is nothing else, but in the ECG. Anyway, go to the, now is the proper echo. This is the first picture I saw, is the parasternal long extremity. The LA is enlarged, but there's something within the LA is there. You can see, you can appreciate it. Something in the LA is there. And as we go, give the color, first things there is a mild, maybe mild to moderate air, and there is a definite moderate to severe MR. And you can see the mitral valve is not normal. You can, there will be a lot of tethering, thickening of the posterior mitral leaflet and thickening, and there is a prolapse. And now go to the next pictures. Now this is the next pictures. Now it is clear, everybody's to what it is. But with this, still the mitral valve holds the tethering of the posterior mitral leaflet and some prolapse of the anterior mitral leaflet, and you can, this is the another view. You can see there is this partition in the left atrium with the aperture, and see the MR and there is not much of gradient if you see across the two chambers. No, but there is a continuous flow. Yeah, there is a continuous flow, but still the continuous flow because of this. See, there is an MR also, and there is a diastolic flow here.
No, but the thing is, on the venous circulation, you will never get a gradient. The only way to know that there is a venous obstruction is a continuous flow.
Okay.
Because you would expect only a systolic and diastolic forward flow across the pulmonary vein. Because pulmonary veins are, all four are going to come to that proximal
All four
chamber.
are going to come to the chamber.
Yeah,
all
so
four
in that case, if you are getting a continuous flow, that itself tells you that there is a venous gradient.
Okay,
But
really,
we
but
won't expect a very large gradient like an arterial circulation.
okay. So that is there, and this, that now is the MR is definitely more than almost a severe MR. Torrential, almost a severe MR.
Look at the pizza and the vena contracta.
Yeah.
And the way it is swirling back.
Swelling back, correct, sir.
60 degrees. We know that this is severe mitral regurgitation. That's the cause of left atrial enlargement, dyspnea and everything. The only issue is what kind of etiology we are discussing when we are talking about this thickened leaflet mitral valve, which there is no prolapse or there is no flail. And flailness. Probably this mitral valve would have to be seen more carefully by a transesophageal.
Okay.
Correct. So you will look for a cleft there. Probably.
Now, this is the right-sided.
Yeah, so
There is a moderate to TBS CRTR.
yeah, and
So
there will
what
be a
is-
pH because of the venous obstruction on the left
Yeah,
side.
so, but important is that what is telling that the pressure in this chamber is definitely very high,
Which one? The proximal chamber.
approximately.
Yeah.
So then the gradient across these two, there will be not much of gradient because LA pressure in this chamber is also high. So gradient won't be there, even if there is obstruction.
This thing happens more often actually in on right side, the quadratum dexter. You don't get a gradient, but you have a full membrane.
Yeah.
On left side, less often, unless there is mitral regurgitation or mitral stenosis.
Yeah.
Then the chamber pressure equalization takes place.
So how much was the pH?
But here
pH is,
also,
I tell you, pH is more than only severe pH.
here also
going
this-
up to more than 4
this
meters.
Tricuspid valve is not normal. That also is slightly thicker.
Yeah, there is some degeneration is there, but not like mitral one, not like mitral one. So I'll go to the another one. It's not like mitral one, but maybe slight thickening of the tricuspid valve is there. Is no gradient across
And
it.
also pericardial effusion.
Yeah, also there is a pericardial effusion. The patient is in some decompensated stage, is a pulmonary edema, and this here. And the GLS is somehow maintained in this patient. This is, remember, this is a 75-year-old man. 75-year-old man. And with this 75, in this age, go to the with a caught triatrium sinistrum to go in this age is itself is a very rare condition. Very rare condition.
It's an achievement.
Then you did the MRI.
Yeah, but then the thing is, before that, let us look at the MR call. I think one mechanism is atriogenic too, because his atria is quite dilated because of the MR. So that annulus is remodeled, so also that is causing the
Means
non-cooptation.
LV is not that
LA.
dilated. LA.
So
LA is
atriogenic.
LA.
I'm calling out atriogenic MR.
LA MR.
Yeah, he's in sinus rhythm. There is no problem.
And there is no doubt in diagnosis. We did the CMR to confirm it. We didn't do the in the 75-year-old man. And what happens is a very high peer pressure. We didn't do the transesophageal, rather we'll go to the CMR to confirm this is. So this is the CMR view, and you can describe this CMR in a better way. I have 3-4 clips, and this is another clip, and this is the cine. and there's a two cines are there, and I'll just show it, and then you can describe.
I think the proximal chamber is draining all the four pulmonary veins. As you go from down and up, I think you can see that there is a,
There's one,
yeah, the
and
first
another one
pulmonary
cine is
vein.
there.
Yeah. So you see, yeah, that pulmonary vein you could
Yeah.
see, and right side also you could see. So both pulmonary, I mean both side
Yeah,
pulmonary
all
veins
have,
are draining into the proximal chamber, and the membrane is below the LA appendage. So that itself is the sign of a cortritis.
Ten sinister.
Yeah.
It's a diagnosis.
If this membrane was beyond the LA appendage, then you will call it as a
Then would have been
suprametal
doubt
ring.
also.
You will call it suprametal ring in that case. Yeah. So that
So
is
heart disease is never too old for congenital heart disease. There is a 73-year-old man. Best important is that men provide a follow-up case of hypertension, hyperdiplomia, congenital esophageal reflux, generalized anxiety disorder. The patient complained of neuropathic pain in the lower extremities and right hand for denied chest discomfort, dyspnea, lightheadedness. He reported taking aspirin, bisoprolol, and one or two cases that is associated with the myxomatous degeneration of the mitral valve. That is there. And the oldest case recorded is a cor tritium in an 86-year-old woman. The initial presentation with pulmonary hypertension discovered during preoperative evaluation. In 86
so that means the MR is multifactorial.
Multifactorial.
There is a myxomatous degeneration and
Agree.
probably atriogenic dilatation of the annulus also.
So in this context, I will show another case of cor tritium with the 8-year-old boy detected murmur in the precordium. And here is I have shown this case is that here the structure is something like C. The structure absolutely close to the mitral valve.
Correct.
And you can see clearly the
It is beyond the LA appendage.
Yeah,
so
beyond the LA
definitely as a suprametal ring. And in these patients also look
And
for
with the
the
severe clearance.
single papillary muscle. You should always look for
Yeah.
a single papillary muscle and a parachute also.
and you can see it one. This is actually the circumferential, and you can see the flow around it is absolutely all from all the sides of the flow is going. And if I can some off-axis view, I can show it. And this is the view. Then you can see this the flow is going around the membranes all around is going like that. And unfortunately, they could not do the MRI in this patient, but it's a high gradient, and so this is the cause. And I'll go to the next case. This 50-year-old man, recurrent chest discomfort, dyspnea, exams, and palpitation for the last 2 years. And here is the intermittent episodes of giddiness with ECG multiple recording with a lot of things, normal to frequent, supraventricular, ventricular premature beat, intercondylar conduction defects, and you can see all sorts of, but no VT. This is the echo first when the patient, this is the echo he presented with some important investigation, and the coronary artery angiogram was absolutely normal. And this patient was put on this CT thorax showing right paracternal lymphadenopathy and right pleural thickening. ACE level is 34, and now see the echocardiogram. And as Dr. Mohan used to say, this is the basal thinning, absolutely the basal thinning you can see in this particular patient, along with the patchy areas of infraposterior wall involvement, and you can see. So this is the net picture, and that's just to compare this with our pictures. And there is some moderate MR, and you can see in the ventricular septum is a very interesting finding. I used to say this is there. I'll go to the ventricular septum very carefully, and you see some beaded appearance with the thinning, not only thinning, basal and mid thinning, and there's some beaded appearance up there. And these beaded, these beaded appearance are very characteristics of the granulomatous infiltration. And this is the net picture, and this is our picture, and what is diagnosed, and this is the inferior vena cava, nothing is there. And this is what Dr. Nitin used to say in a patient of the granulomatous infiltration, the variegated appearance of in the GLS. You can see this is not conforming to any of the coronary artery territories. So this is the echo. And most important finding to show is the abnormal thinning of the basal interventricular septum with the patchy areas of bright recurrence. We call it speckled or a snowstorm pattern due to areas of granulomatous infiltration. And this is findings a very high suggestive of cardiac sarcoidosis. And we did ultimately opacity thorax, MRI, and this is another patient, this niche patient, the similar picture was found, and you see the same picture. This is not the same patient. And now, Nitin, to describe, I don't know about the MRI about this in this patient, and you can tell me about the MRI in this patient. There are a lot of
I think you can see those white areas in the myocardium, because the myocardium in this particular sequence should be black. So you have got those white spotty areas with a predilection for the proximal septum. So those are probably the fibrosed granulomas.
Less
granulomas, because that kind of a distribution can happen only when you have got focal injury. So probably it is related to the granuloma. So you would try to look for the lymph node to biopsy in this particular patient.
TB and lymph node biopsy has been done,
correct.
and this patient was proved to be a case of sarcoidosis.
Correct. But for knowing the activity of these,
Yes,
you
certainly.
need a PET CT.
Yeah.
You need a PET CT because that will tell you whether
Yes,
you are...
we did the PET CT and also the PET CT cardiac MRI, and also if you can describe this PET CT. I don't know about the PET CT, but this is there. What they have suggested is that dilated gadolinium enhancement is found predominantly in the mid-myocardium and the epicardial areas, but rarely in the endocardium, mainly at the basal and the lateral segment of the left ventricle. Perfusion defect with intense FDG uptake in their region suggestive of myocardial inflammation. Normal myocardium has no FDG uptake because it is urine-free fatty
I
acid.
think there is a problem with this FDG.
Yeah.
There is no myocardial suppression done. You should not have such an intense FDG uptake in the myocardium because you have to really, because see, this is FDG.
There was inflammation and this patient was put on EBAS guided aspirate. Also TB and a biopsy was inadequate sampling, but EBAS guided aspirated the same thing. This patient was started on the immunosuppressive therapy with the prednisone in such and such dose, with a follow-up tapering dose with a careful assessment of cardiac, and patient is doing well, very well.
I have a question to all this whole thing. You know, this kind of pattern of sarcoidosis, and we know our limitation of not being able to get PET. We certainly feel that in a case like this, MRI not adding much information, because you have typical appearance.
In the echo.
Echo. The question is, can we, without showing activity, start steroids in a person who has frequent ventricular ectopy?
If you are telling about if the patient is having tuberculosis, his patient might have due to tuberculosis.
No, the question actually is, we are seeing far more patients like sarcotuberculosis, tuberculosis.
Yeah, that's why that is
the issue actually is that whenever we get actually PET CT done in these cases, report is always more confusing than it solves the problem.
So then what to do? Even if you would getting a case, even if you would getting the non-caseating granuloma in the biopsy, that is proved to be tuberculosis again.
Yeah, again tuberculosis. But the thing is,
So
just
then
go
what to
back
do,
to
sir?
the
You have
PET
to point in
CT.
certain such cases.
Yeah, I think the best...
In all cases, you have to be getting the cultures and all these things is very difficult. Sir, keeping in this mind the clinical pictures of all these, having the chest pain and these varieties of ECG abnormalities, sarcoidosis is more likely, but I don't know whether even tuberculosis can give rise to
But that doesn't shed light on activity because your arrhythmias could be related to the old fibrous structure also.
One could look at the ESR, CRP, other kind of things, say the patient is active. But if no
Even the
fever, loss of weight, but if those things are not there, which is usual in our the time patient comes to us with AV block, bundle branch block, sometimes heart failure, sometimes only ventricular ectopy, we don't know what to do. In fact, unfortunate thing is, this is an area where I am looking for a simpler solution. How to treat them. And this PET CT business, I am finding really, I am very enthusiastic about getting it done, but unfortunately it's not helping me. It appears every
more
case,
confusing.
Yeah, it's more confusing. And some people, of course, from Hyderabad, the Narasimhan group said that you need to actually prepare patients very well, keep them only on fat diet for 2 days or 3 days, and then pure fat diet, and then do it, and then only you will find. Otherwise, you will get confused whether activity is there or not.
Okay, here is another interesting case, sir. Last, if time permits, otherwise I'll show 2 cases. 9-year-old boy presented with the cyanosis claving, shortness of breath, class 3, mild hepatomegaly. You can see the cyanosis, claving, and This is the chest X-ray is not giving any clue. I don't think so. And the ECG is a very old one, and is not giving any. I think not much of it. But see the very characteristics echo. So first put in these, the RV looks shorter. RV looks hypoplastic, and the LV is something like some apical bulging is there, could be. So, but look at the very carefully. So this is there. All the ends, the RV and the tricuspid valve are looking a little hypoplastic, and this is the RV outflow tract is absolutely well formed, and even I measured the Z score of tricuspid annulus that is within normal limit. But look at this, sir, LV lateral wall, it is absolutely smooth. And look at this septal wall, particularly in the upper part, is totally trabeculated. And where is the moderator band, you can see, beyond the moderator band, you see the absolutely trabeculated appearance. So here is a distinct morphology. You can see, first thing you go to the subcostal, there is a PFO and with absolutely right to left shunt. And VSD, VSD. No, sir, there is no VSD. I am show you, there is no VSD, sir. Oh, no VSD. Yeah, contrast. I don't have a contrast echo in this, but there is no VSD, sir. Okay, there is no VSD, but tricuspid inflow and is good, and there is some in and flow TR is also there, and you can see the right to left shunt, and there is a lot of pictures are there. You can flow. So this is probably the last case because a lot of time is there. So basically, this is very another large apical ventricular septal defect with separation of the right ventricular apex from the remaining RV by excessive trabeculation, and thereby eliminating of any left to right shunt across the ventricular septal defect. Basically, these are the very rare and distinct type of morphology. Only 3 to 4 cases reported in the world, one from the Calcutta itself by Dr. Achut Sarkar is there, not in there. Physiologically, there was no apparent hemorrhagic disturbance, but why there is a cyanosis and clubbing?
I think the RA cannot decompress into the RV. So probably that's why the RA pressures must be high.
Yeah,
because
that's why
your
there is a right
PFO was shunting continuously right to left. So
Yeah.
that could be there.
This is hypoplastic right heart syndrome with apical isolation. It is well described. Apical isolation of the RV apex and with the hypoplastic, because the tricuspid annulus is half the size of the mitral annulus.
No, so Z score is normal. See, said tricuspid annular diameter is 16 millimeter with Z score minus what, 1.86.
Small RV cavity, that's why the
It does, and of course,
that is because of cyanosis is happening.
right to left shunting. But this is actually what we call it apical isolation.
But say, 8-year-old boy, 1.86 Z score is also within normal limit.
I don't think that there is something wrong. I look at the mitral annulus that is much bigger than tricuspid.
Yeah, that's
annulus.
there.
For me, it is hypoplastic right heart.
Acha, said, okay, anyway, the shunt is because of the pressure difference is there. And this is actually the happening, this is the physiology is happening, ultimately the VSD become, first is the VSD was there, and ultimately the moderator blend closed the VSD. Close the VSD.
like a 1.5 ventricle.
Yeah, 1 minute. So this patient was actually, if you do the MRI, they got a very interesting finding. Say the mid panel, there is a morphological LV is colored in red, and the morphological RV in the blue, and the morphological RV but functional LV in green, and the uncolored bright blood pool between the red and blue resembling the old VSD that was being closed. So that's a distinct different entity. This type of apical VSD constituted a rare and distinct type of morphology, physiology, and has to be considered in patient with suspected LV aneurysm, absent of coronary artery disease, and lack of any heart murmur. Our patient is symptomatic with class 3 DOA, but we do not know what to do with the patient. Yeah, only the fontan is the.
All right, thank you.
So, I think we'll stop here because of the lack of time. Okay?